Welcome to the CME certified activity entitled Integrating the Latest Advances into Clinical Practice, Data and Expert Insights from the 2016 Meeting on Genitourinary Cancers in San Francisco. This educational activity is jointly provided by the Annenberg Center for Health Sciences at Eisenhower and Access Medical Education in collaboration with Postgraduate Institution for Medicine and is supported by an educational grant from Genentech. My name is Dr. Jean Hoffman-Censits, Assistant Professor in the Department of Medical Oncology and Director of the Genitourinary Multidisciplinary Clinic at the Sidney Kimmel Cancer Center at Thomas Jefferson University in Philadelphia, Pennsylvania. My disclosures include an advisory board member for Roche Genentech. Our discussion today will include the most exciting and compelling data in bladder cancer from the 2016 Genitourinary Cancers Meeting and insights on how these clinical advances may be practice-changing. So let's begin. The first study I'd like to highlight is abstract number 354 by Falsitz and colleagues, generating a neoantigen map of advanced urothelial cancer by whole exome sequencing. So the idea behind this study, the reason I'd like to highlight this study is I think it really nicely complements some of the clinical work that's being done with checkpoint blockade and immunotherapy in urothelial cancer. The immune system differentiates between self and foreign proteins, balancing surveillance and attack against viral and bacterial antigens with control to prevent autoimmunity. As cancers mutate and continually form foreign proteins, these cancer neoantigens can be recognized by the immune system and thus can potentially lead to an anti-tumor immune response. These cancer neoantigens can arise from somatic mutations, and as we've seen in several clinical scenarios, such as in melanoma and in lung cancer, a higher mutational load is correlated to response to checkpoint inhibitor therapy. Interestingly, bladder cancer rivals lung cancer and melanoma in terms of mutational burden, thus in part justifying the role of checkpoint therapy in this disease. So, how does mutational burden potentially lead to response to immunotherapy? DNA with somatic mutation is translated to mutant proteins, which are then processed similarly to other foreign proteins and presented to immune effector cells. This activates an immune response. The theory behind checkpoint inhibitor blockade is that pre-existing or primed anti-tumor immune response can be unleashed by unlocking the local brakes that have kept the anti-tumor immune response in check. Therefore, these authors looked to evaluate neoantigens as a potential biomarker of response to immunotherapy in patients with platinum-refractory urothelial cancers and how these can evolve through the disease process. One of the primary aims of the study was to characterize differences in neoantigenic signatures between primary and metastatic tumors. And the authors were uniquely positioned to do this as they had multiple tumor samples within same patients from initial diagnosis through recurrence and sometimes in the chemo-refractory state, which were evaluated through whole exome sequencing. The results showed that there was a significant correlation between somatic mutations and the neoepitope burden, and significant increases in neoepitopes in metastatic samples compared to matched primary cancer samples within the same patient. In fact, on average, about 30% of the neoepitopes were shared, comparing primary to metastatic samples. Some of these changes evolved de novo in metastasis, while others evolved during or in part potentially related to selective pressures, such as surgery or chemotherapy. The second study I'd like to highlight is abstract 357 by Dr. Galsky and colleagues, a phase 2 trial of gemcitabine and cisplatin with ipilimumab in patients with metastatic urothelial cancer. So the preclinical rationale behind this combination includes a very small study that was done, a window trial of ipilimumab prior to cystectomy in about 10 patients that showed some local immune modulatory effects, as well as the potential addition of immunomodulatory effects of chemotherapy with CTLA-4 blockade, with the thought that chemotherapy could potentially lead to cell death, which releases neoantigens. As Dr. Galsky pointed out, a potential auto-vaccination by combination of chemotherapy, as well as potential direct modulation of immune subsets, such as depletion of myeloid-derived suppressor cells with chemotherapy, as well as some synergy seen in preclinical models. I think this study is important to point out because it is the first study combining chemotherapy with CTLA-4 blockade. This was a phase 2 study, and it was a phased treatment, 2 cycles of gemcitabine and cisplatin, and then followed by 4 additional cycles of gemcitabine and cisplatin combined with ipilimumab, and this was in the first-line setting in platinum-eligible patients. The dose of ipilimumab was somewhat higher than the FDA-approved dose for melanoma. The dose in this study was 10 milligrams per kilogram. And if after 6 cycles of chemotherapy patients had at least stable disease, they could be remained on ipilimumab maintenance therapy. In this study, 36 patients were enrolled. They had a median age of 60. Patients had primary bladder cancer, and over half of the patients had visceral disease at the time of presentation, which portends a worse overall survival. The median number of treatments received was 5 cycles of chemotherapy and 3 cycles of ipilimumab, and the majority of patients who came off of study did so due to progression of disease. Although the majority of the adverse events and toxicity seen on the study were grade 1 and grade 2, 72% of patients did have more significant grade 3 and 4 toxicity. Most of these toxicities were hematologic, but other immune-related toxicities that are consistent with ipilimumab were also seen. Dr. Galsky and colleagues pointed out that these were felt to be additive and not necessarily synergistic. The objective response in this group was 64%, and this included an impressive 14% of patients that had a complete response. One of the things I think was notable in this study was that 17% of patients experienced an improved response after the addition of ipilimumab, so essentially after their first 2 cycles of chemotherapy, compared to how they did with cisplatin and gemcitabine alone. It's not clear if this finding was actually additive when ipilimumab was added into the regimen, or would this have happened anyway as the patient maybe would have just responded to additional chemotherapy? This can't be answered with the study, but is certainly compelling. The primary endpoint on the study was 1-year overall survival, and that was 59%, so again did not reach the primary endpoint as the study was designed. The median overall survival was 14.6 months, and this is very consistent with other trials of first-line cisplatin and gemcitabine. One of the other very interesting things that was done in this study was to determine immunomodulatory effects of treatment, both with cisplatin and gemcitabine alone, as well as following the addition of ipilimumab to the regimen. Following just 2 cycles of cisplatin and gemcitabine, there were no changes in terms of peripheral blood immunocytes and no clear pattern of change in terms of inflammatory cytokines and chemokines. However, after the addition of ipilimumab, there was a significant expansion of CD4 and CD8 T cells, as well as a cluster of patients with an increase in inflammatory cytokines and chemokines that were characteristic of T cell activation, trafficking, as well as NK cell activation. So as I mentioned earlier, I think this trial is very important to highlight because it is the first trial that has been initiated to explore immune checkpoint blockade in combination with chemotherapy. The toxicity, as I had stated, appeared to be additive and not synergistic, so we weren't seeing necessarily any toxicities other than that expected either with cisplatin and gemcitabine or with ipilimumab. I think it's also interesting that there were pharmacodynamic effects seen despite chemotherapy and steroid therapy in combination with ipilimumab, and more work I think needs to be done to define whether or not these treatments together are necessarily going to be synergistic. The next study I'd like to highlight is abstract number 355. This is the INVIGOR-210 study, a phase 2 trial of atezolizumab, or MPDL3280A, in platinum-treated locally advanced or metastatic urothelial cancer, and I had the honor and pleasure of presenting these data. So atezolizumab is an engineered anti-PD-L1 monoclonal antibody with the hypothesis that it can reinvigorate suppressed immune cells and potentially lead to an anti-tumor response. INVIGOR-210 enrolled patients with metastatic urothelial cancer. These patients could progress either during or following cisplatin chemotherapy, and there were no restrictions on the number of lines of prior chemotherapy, so this is not a pure second-line study. All patients had to submit samples for testing of PD-L1 expression, and this expression was determined on tumor-infiltrating immune cells. This expression was scored on 3 levels by immunohistochemistry. Greater than 5% was IC2-3, between 1 and 5% was IC1, and less than 1% was IC0. Although these IHC testing was done prospectively, the results of the IHC testing were blinded both to the patient and investigator during the course of the study. This was a 2-cohort study. Cohort 1 involved patients that were platinum ineligible, and this cohort has not yet been presented. And so at ASCO 2016, we presented cohort 2 of 310 patients. Patients had a reasonable functional status as well as, and could have renal insufficiency, and received atezolizumab 1,200 milligrams every 3 weeks until the loss of clinical benefit. The co-primary endpoints were looking for objective response by RECIST measures, as well as duration of response, safety, and overall survival. I think notably as well that this was a very heavily pretreated population of patients, with 41% being treated in the 3rd line and beyond. Notably with significant proportion of patients that had renal insufficiency as well as visceral metastatic disease. Also with these studies, we're starting to define this biomarker, which is looking at PD-L1 on tumor-infiltrating immune cells, and the distribution of overexpression and underexpression was even throughout the population. Objective response by central RECIST review was 26% for the IC2-3 subgroup, 18% for the IC1-2-3 subgroup, and for all comers there was a 15% response. Surprisingly, complete responses were also noted on this study of 11% in the IC2-3 subgroup and 5% overall. All of the pre-specified subgroups met the primary endpoint of the study, which was a 10% objective response compared to historic controls in the 2nd line and beyond. And although higher response rates were associated with higher PD-L1 IHC status, responses, including complete responses, were seen in the IC1 and IC0 subgroups, with responses of 10 and 8% and complete responses of 2% in IC1 and IC0 subgroups. Patients who responded on this study tended to have very durable responses, with the median duration of response not reached in any of the PD-L1 subgroups. And 84% of patients who were responding continued to experience an ongoing response at the time of data cutoff, which was a median follow-up of 11.7 months. With a median follow-up of 11.7 months, the median overall survival was 11.4 months in the IC2-3 subgroup, or the PD-L1 overexpressors, 6.7 months in the IC0 group, and 7.9 months for all patients. The 12-month overall survival was 48% for the IC2-3 subgroup, 30% in the IC01 subgroup, and 36% for all patients. In terms of safety, treatment-related adverse events were seen in 69% of patients overall. The rate of serious adverse events was 11%. In grade 3 or 4 adverse events, 16%. There were no treatment-related deaths on study, and a relatively low incidence of immune-related adverse events, 7%. Given that this is an immunotherapy study, that's certainly something that we wanted to capture. The median number of doses on study was 5, with a range of up to 23 doses at the time of data cutoff. So in conclusion, with overall responses compared to a historic control of 10%, and given the relatively well-tolerated agent, it felt that atezolizumab may potentially change the standard of care for patients who have failed cisplatin-based chemotherapy, either in the perioperative or first-line setting. Higher PD-L1 immunohistochemistry immune cell status was associated with higher response rates. However, low expression does not preclude response. and the median duration of these responses had not yet been reached in any of the PD-L1 or poor prognostic subgroups. The median overall survival was 11.4 months. The next study I want to highlight is abstract number 367 by Dr. Andrea Polo and colleagues, Safety, Clinical Activity, and PD-L1 Expression of Avelumab. It's an anti-PD-L1 antibody in patients with metastatic urothelial carcinoma from the Javelin Solid Tumor Phase 1b study. So in this study, similar to the atezolizumab study, patients were unselected for PD-L1 expression, although this expression was noted and recorded, received avelumab at 10 milligrams per kilogram every 2 weeks until confirmed progression on acceptable toxicity. 44 patients who had metastatic urothelial cancer treated in the second line and beyond following platinum chemotherapy were treated with avelumab range between 2 and 28 weeks on study, and they were followed for a median of 3.5 months. The median age on this study was 68 years, and patients on this study also tended to be heavily pretreated with a median number of 2 prior therapies in a range between 1 and 4 prior therapies. Adverse events occurred in 59% of patients and included infusion reactions, grade 1 or grade 2, as well as fatigue. Similar to the atezolizumab study, there were no treatment-related deaths. Of the entire population, the response rate was 15.9%, including 1 patient with a complete response, and 6 patients were having an ongoing response at the time of data cutoff. 42% of patients exhibited stable disease with a total disease control rate of 59%. PD-L1 expression in this study was evaluated on tumor cells, and looking at the selected group of patients who overexpressed or had a greater than 5% expression of PD-L1, the response rate was 40%. When you looked at patients who had underexpression of PD-L1 or no expression, the response rate was 9%. So the overall results of this study demonstrated that avelumab had an acceptable toxicity profile in patients with metastatic urothelial cancer. There was a trend towards higher response in those patients whose tumor overexpressed the biomarker PD-L1, and this trial is actually continuing to enroll. The final abstract I'd like to talk about is abstract number 356 by Dr. Zagul and colleagues, a randomized clinical trial comparing adjuvant radiation versus chemoradiation versus chemotherapy alone after radical cystectomy for locally advanced bladder cancer. So this study was conducted by investigators in Egypt with collaboration with the Egyptian National Cancer Institute, and then analyzed by a partnership with the University of Pennsylvania. So the authors of this study discussed that the pelvis is a common area for patients with advanced bladder cancer to fail following local therapy. Radiotherapy is standard of care in Egypt, but the majority of tumors are squamous. And radiotherapy following surgery led to improved disease-free and overall survival compared to surgery alone in a study that was completed in the 1980s and 90s in Egypt. So the authors questioned about, what would be the benefit of combining adjuvant chemotherapy with adjuvant radiotherapy. This study evolved over time. The original purpose of the study was to determine whether or not sequential adjuvant chemotherapy added to adjuvant radiotherapy improved disease-free survival over adjuvant radiotherapy alone. This original design was, of course, relevant in Egypt, where adjuvant radiotherapy is standard of care, but to increase potential impact of this trial in countries where this is not the case, the design was later amended to include an arm that was an adjuvant chemotherapy alone arm. The goal of this would be to hope to answer the question if adjuvant radiotherapy with or without chemotherapy is better than adjuvant chemotherapy alone. As the adjuvant chemotherapy alone arm was added later, the randomization was weighted to this arm in order to enhance accrual. So question number 1 was the adjuvant chemotherapy question. Does chemotherapy add to adjuvant radiotherapy? And question number 2 was chemotherapy plus radiotherapy versus chemotherapy alone, see if there was a benefit in terms of adding it to adjuvant radiotherapy. The primary endpoint was disease-free survival, and the secondary endpoint, overall survival, local recurrence-free survival, distant metastasis-free survival, and toxicity. The population of the study included patients post-radical cystectomy with one or more high-risk features for local failure, and these were stage greater than or equal to pathologic T3B, grade 3 tumors, or patients that had lymph node positive tumors. The study only enrolled patients who were less than 70 years old and with performance status of 0-2. The design of the study, the schema of the study, 78 patients underwent adjuvant radiotherapy, 45 centigrade BID for 3 weeks. 75 patients were randomized to the arm that received cisplatin and gemcitabine at standard doses, followed by, for 2 cycles, followed by adjuvant radiotherapy at 45 gray BID, followed by 2 additional cycles of gemcitabine and cisplatin, then this was referred to as the sandwich regimen, and finally 45 patients who received 4 cycles of cisplatin and gemcitabine alone. The median age on the study was 54 years. This is younger than we see typically in advanced urothelial studies in the United States. 53% had urothelial carcinoma, 41% had squamous cell carcinoma, and 6% had other cancers. So looking at question number 1, chemoradiotherapy versus radiotherapy alone. In the baseline population, the patients who were randomized to the chemoradiotherapy alone arm were slightly younger. The authors found no significant difference in disease-free survival and local recurrence-free survival or overall survival, but there were non-significant trends towards improvement in the combined arm for each of these endpoints. Looking at question number 2, chemoradiotherapy versus chemotherapy alone. Looking at the population enrolled onto study, patients on the chemoradiotherapy alone arm were slightly younger, and the tumor size was larger in the chemotherapy alone arm. There were trends towards disease-free survival in the combined chemoradiotherapy arm. There was a significant benefit in the chemoradiotherapy combined arm at 3 years in terms of local recurrence-free survival compared to chemotherapy alone, and that was 96% versus 69%. But there was no difference in distant metastasis-free survival or overall survival at 3 years. Looking at toxicity, there was a small risk of late grade 3 or greater gastrointestinal toxicity in the radiation arms with or without chemotherapy at 7 and 8% versus chemotherapy alone at 2%. The authors note that the study was limited by a small sample size in the groups, and the weighted randomization of the addition of the chemotherapy alone arm led to imbalances in the patient populations in terms of age and tumor size. In addition, the tumor heterogeneity on the study with a significant proportion of patients that had squamous cell carcinoma does limit the generalizability of these findings outside of countries where squamous cell carcinoma is incredibly common. So in conclusion, I'd like to summarize what discussed and how these studies can be applied to clinical practice. Looking at Dr. Faltz's study, I think it's clear that he showed it in his work that metastases have a higher level of neoantigen load compared to primary tumors. The question is whether or not this is driven by tumor biology, that as metastases occur, there's a natural evolution of these neoantigens, or because this was studied in a population of patients that had received and failed platinum-based chemotherapy, are these neoantigens being driven by the presence of chemotherapy? I think additional studies will help us understand that. As reviewed in the expert commentary from Dr. Billy Kim, what are the implications of the work from Dr. Faltz's and colleagues, showing neoantigen formation changes and expands in advanced disease states? As investigation of checkpoint inhibitor therapy moves into earlier and earlier states of disease, Will responses be as robust as those seen in the INVIGOR and other late-line post-platinum studies? Or will the relatively limited neoantigen status, compared to potentially that seen in the advanced setting in chemotherapy-naive primary tumors, lead to less profound anti-tumor immunity? Dr. Faust has presented important hypothesis-generating work that may be relevant for patient selection for checkpoint inhibitor therapy. The question may be in part answered by seeing the response rates from Cohort 1 in INVIGOR 210 in the treatment-naive platinum-ineligible group of the atezolizumab study. Looking at Dr. Galsky's study, the addition of ipilimumab to gemcitabine and cisplatin, this study did not meet its primary endpoint for overall survival, and the toxicity of the addition of ipilimumab to chemotherapy was certainly notable. It was intriguing that there was an improvement in objective response compared to historic controls, and as well as that the addition of ipilimumab increased the proportion of CD4 and CD8 T cells and increased in inflammatory cytokines. It's not clear the importance of this or the mechanism, but I think compelling work and certainly very important component of this study, understanding the biology of the addition of checkpoint blockade to chemotherapy. As Dr. Galsky mentioned in his conclusions, our current armamentarium for urothelial cancers is based in cytotoxic chemotherapy, and given all the very encouraging results that are seen with checkpoint and immunotherapy, there are still unanswered questions regarding the best way of combining or sequencing these therapies. But I think very importantly, as he mentioned, the study demonstrated that the combination is feasible and that there was a pharmacodynamic effect despite being chemotherapy and checkpoint blockade being given simultaneously. There is an ongoing study of cabozantinib plus nivolumab alone or in combination with ipilimumab, as well as several ongoing combination studies of PD-L1 or PD-L1 inhibitors. In terms of the atezolizumab study, I think it's important to highlight that even in very heavily pretreated patients, there was an impressive objective response rate, and that in patients with advanced urothelial cancer who are plagued by comorbidities including fatigue, anemia, and renal insufficiency in a population of patients that has been traditionally very difficult to treat and maintain on clinical trials, that this was a very well-tolerated regimen with a low treatment-related grade 3 and 4 toxicities and no treatment-related deaths. I think also notable was that patients who responded on this study tend to have durable responses, as well as the impressive complete responses on the study. There are several studies of atezolizumab ongoing, including a phase 3 open-label study randomizing patients in the second line to atezolizumab versus chemotherapy, which is physician's choice, paclitaxel, docetaxel, or vinflunine in Europe, and the study is ongoing. There are two other studies of note. One is an expanded access program, atezolizumab in patients who progressed post-platinum therapy, as well as an adjuvant study of atezolizumab versus observation in patients post-cystectomy that have high-risk features, and this is stratified based on whether or not patients receive neoadjuvant chemotherapy. Dr. Apollo's study of avelumab similarly showed impressive response looking at the selected group of patients where the tumor overexpressed PD-L1 of 40%, as well as showing some of the patients in that study had durable response. I think looking at these studies together, these studies further lend really compelling evidence of the efficacy of PD-L1 blockade even in heavily pretreated patients, and really starts to solidify the role of PD-L1 expression as a biomarker of a response. I think importantly that higher responses based on higher PD-L1 expression were seen in both studies, but responses were also seen in those with low or no expression. And I think that this is important, especially as we look at patients with urothelial cancer progressing following platinum-based chemotherapy who really have no other options for therapy. I think that this will be a continued discussion about the role of PD-L1 as a biomarker, especially as these agents start to move forward and these and others may become available outside of the investigational setting. I think it's also important to note that even in patients that have had stable disease on these studies, some of these patients have had durable responses as well. And this is also important as these patients, I think, are getting some clinical benefit from these agents. And finally, I think the take-home from the adjuvant study combining chemotherapy and radiotherapy versus chemotherapy alone, the Egyptian study, is that there were less local recurrences in the cohorts that underwent treatment with radiation compared to that cohort that had chemotherapy alone. This study, however, had many limitations, in part the differences in populations at randomization, including larger tumors and more locally advanced tumors seen in the chemotherapy alone arm. So one cannot completely conclude that the differences that were seen weren't necessarily just related to the differences in the baseline characteristics of the patients. In terms of looking at this study for how it may be interpreted for an American population, this study included a very large percent of patients with non-urothelial histologies, which is not common in the United States. And this really makes it more challenging to generalize the data. And finally, although there was a difference in local recurrence-free survival, there was no difference in terms of overall survival. So, what impact does that endpoint really have when we consider the toxicity and expense and time of therapy? Currently, adjuvant radiotherapy should continue to be considered investigational, and there are many ongoing studies, including a large national study ongoing, looking at the role of adjuvant chemotherapy in patients with urothelial cancer with high-risk features following cystectomy. With that, we'll conclude this activity, and I thank you for your participation.